Good morning. Good morning. Can you hear me? Excellent. Thank you. Welcome to No and Go Friday. I'm Holly Brenner, the Director of Marketing and Public Relations for our system. Thanks for being here again this morning. Looks like it might be a nice one out there. I'm glad to be able to introduce Dr. Grossman to you this morning and have him talk to you a little bit about the Agnesian Center for Bone and Joint Health and the things that happen over there. But before we get into that, there are a few things that we need to address. First, I'll check in with Wapan, Shelley, and Ripon and Danelle and Ripon. Can you hear us?
I can hear you. It's a little bit quiet, but we can hear you.
I'll speak up. Shelley, can you hear us?
We're doing great in Wapan.
Excellent. She's off of mute now. And I'd also like to share a reflection. This is titled Live for Now. There are 2 days in every week that we should not worry about. 2 days that should be kept free from fear and apprehension. One is yesterday with its mistakes and cares, its faults and blunders, its aches and pains. Yesterday has passed forever, beyond our control. All the power in the world cannot bring back yesterday. We cannot undo a single act we performed, nor can we erase a single word we've said, for yesterday is gone. The other day we shouldn't worry about is tomorrow, with its impossible adversaries, its burdens, its hopeful promise or poor performance. Tomorrow is beyond our control, and tomorrow's sun will rise either in splendor or behind a mask of clouds. However, it will rise, and until it does, we have no stake in tomorrow, for it is yet unborn. This leaves only one day, today. Any person can fight the battles of just one day. It is only when we add the burdens of yesterday and tomorrow that we break down. It is not the experience of today that drives people to despair. It's the remorse of bitterness for something which happened yesterday and the dread of what tomorrow may bring. So, therefore, live and enjoy one day at a time, and that day is today. As a reminder, our No and Go Fridays are really designed to help educate us as associates about important health information and to introduce us to the providers and associates within Agnesian HealthCare who provide those services. Because the more we know about what we do here within Agnesian HealthCare, the better prepared we'll be to talk to people and to let them know what happens here. We'll be able to share that information. Someone asked me a question about our next No and Go Friday session in July, and the tone of that is a little different than what we've seen in the past, so I just wanted to address that. We're talking with Dr. Joseph on July 12th about CPOM, and how does that fit into No and Go series. I recognize that it's a little different from the norm, but this is something that's very important as we address the overall efficiency and accuracy of the work that we do here. Agnesian HealthCare has made significant investments of time and all sorts of resources and is committed to CPOM. So it is in that interest that we're bringing Dr. Joseph, who is our Chief Medical Information Officer, forward next month. So I promise that will be entertaining, if nothing else. A little bit of housekeeping. We've changed a few things this time based on your feedback. So these yellow slips, we really do take these to heart, and the information that you provide, we work to incorporate or to act on it as it's appropriate. And one thing that we changed today, we don't have a sign-up sheet for attendance today. So rather than passing around another sheet, please, if you're interested in getting credit for being here this morning, put your ID, your associate ID number on this blue slip. I'm making an assumption here that most people wanted to register for that prize. So this is how we'll be keeping attendance. Okay, so I guess without any further ado, we'll bring Dr. Grossman to the front here. He's here to share his stories about what he does. He's been serving us as an orthopedic surgeon at Waupun Memorial Hospital for about the last 5 years, and I think you'll find what he has to share very interesting. So welcome, Dr. Grossman.
Thank you. I'm very happy to be here today. What I'd like to talk today is about places that orthopedics or orthopedic surgery enters your life. And we're going to look at a couple of different phases of that. Somebody said that sometimes people are interested in what the doctors are and who they do things to and how they got there. So I'll let you know. I grew up in Wisconsin. I left when I was 18 and went into the Navy, and I got out 12 years ago. I trained in the Navy as an orthopedic surgeon, but I was also in the regular Navy. So if anybody has any questions about celestial navigation, steam turbines, or cruise missile systems, I'd be happy to talk about that later on. As Holly said, I am Agnesian's orthopedic surgeon in Waupun. I am there by myself. I have a nurse practitioner, Margie Anderson, that helps me. We see the full spectrum of patients, babies to geriatric folks. I thought what we'd do today is talk a little bit about the folks that are in orthopedics and Agnesian. First of all, there are a lot of us actually. Most of us are here in Fond du Lac. Like I said, this is Margie Anderson, who's with me in Waupun. I wanted to go over a little bit of history. What is orthopedics? And it really means straight children. And the term came up in the mid-1700s. The Latin orthos pedion is for straight child. And this was how the specialty began. Skeletal deformities in children. In 1780, the first hospital dedicated to the treatment of children's deformities was formed. Any of you that are a little bit older have remembered getting plaster of Paris casts. Well, plaster of Paris was invented in 1851 by a Dutch military surgeon. Prior to that, the way that broken bones were held is sort of gross sounding, but basically they would put bandages on, soak them in blood, they'd get stiff and hard, and that would be what was done. They smelled bad and they were a sanitary nightmare, and so plaster of Paris was invented as a more sanitary way to take care of these things. The core of orthopedic surgery or orthopedics is correction of spinal and bony deformities. That's what we do. Orthopedic surgeons are a surgical specialty. We operate on the musculoskeletal system, which is bones, joints, tendons, ligaments, some nerve surgery, and some of us will repair blood vessels from time to time if it happens to be a problem. Who are we? Well, there are about 20,400 orthopedic surgeons in the United States. About 700 new orthopedic surgeons graduate every year. About 3 or 4% of all physicians are orthopedic surgeons. It is an overwhelmingly male profession. You do not have to be strong to be an orthopedic surgeon. There's a lot that we do that involves tools or instruments, if you want to call them that. But you don't have to be strong to be an orthopedic surgeon. You just have to know about leverage. And so it just happens to be overwhelmingly male. That's all there is to it. The average age of orthopedic surgeons is about 55, and it's going up. In Wisconsin, there are about 10 orthopedic surgeons for every 100,000 people. Wisconsin, if you want to know how Wisconsin ranks, that's about the middle ground. If you want to know the state that has the most orthopedic surgeons per 100,000, it's Wyoming. For some reason, they've got almost 16 per 100,000. Maybe that's because there are only 32 orthopedic surgeons and 200,000 people in Wyoming, but that's about what it is. In Wisconsin, there are about 560 orthopedic surgeons. People sort of like to know what we do. So this is kind of like Dave Letterman's top 10 lists. So probably the 10th most popular thing is we operate on the radius and the ulna. The radius and the ulna are the two bones in the forearm. The radius is on the thumb side, the ulna is on the small finger side. The next most popular thing is the rotator cuff. The rotator cuff is basically one tendon powered by 4 muscles that lets us start shoulder motion. And basically, if you're over about 40 years old, your rotator cuff is wearing out, and you might come and see us about it. We replace hips. We operate on hip fractures. We replace knees. I'm going to go into this a little bit more in detail later on. The anterior cruciate ligament, or ACL, is one of the 2 ligaments inside the knee that crosses and provides stability. One of the other things that we do is when we repair fractures, we use some orthopedic hardware, plates and screws. So if we put it in, we take it out. Carpal tunnel, you might know, is numbness and tingling in these 3 fingers, and sometimes just half of the ring finger. A little bit of a fun fact, this side of the ring finger, the side closest to the thumb, has sensation provided by one nerve. This side, the small finger side, gives sensation from another nerve. So you're not crazy if you have carpal tunnel and half of your finger feels fine and the other half doesn't. Shoulder arthroscopy. Arthroscopy is the operation where we make some small poke holes and insert fiber optic instruments into the joints and do the repair inside the joint rather than opening up the body. The most popular thing that we do, knee arthroscopy. Again, make some poke holes in the knee, insert the fiber optic instruments, and repair or remove the structures on the inside. Meniscectomy. The menisci are two C-shaped pieces of cartilage inside the knee that provide cushioning and location. And so if you hear somebody says, I tore cartilage in my knee, probably means they tore their meniscus. Like I said, orthopedics or orthopedic surgery, we are surgeons. This means we can operate. We don't have to operate on everything that comes through the door. And in my practice, about half of the folks that I see, I treat without operations. Everybody's different. Some people have a higher percentage, some people have a lower percentage, but just going to the orthopedic surgeon doesn't mean that we're going to hit you on the head and operate on your knee in the office. We're going to talk first. I spoke a little bit before about how we want to look at orthopedics in different places that it enters in your life or your children's lives. And like I said, ortho means straight children. So I wanted to talk about children first. It's important to realize that children are not small adults. There is a very, very unique anatomy of the growing bones. If you look at this, this happens to be the ankle of a child. This big bone here is called the tibia, it's the shin bone. This little bone over here is called the fibula. It's the bump on the outboard side of the ankle. And this dark line right there is the growth plate. If you have to think about it, you remember babies get bigger, somehow the bones have to grow, and they grow from the ends, or the growth plates. And this is sort of a magical area because these cells are actually cartilage cells, and they turn into bone cells. And that's where growth occurs. Children don't sprain things, for the most part. So if you have a child that falls down and hurts their wrist and it's kind of swollen, they broke something. They don't sprain things. The growth plate is weaker than the rest of the bone. So if there is something that's going to happen, a slip, a fall, a twist, they're probably going to break the growth plate. And there are different ways that the growth plate can get injured. The typical one that we see sometimes is the sprain that isn't really a sprain. The child comes in with their parents. They fell a couple of days ago. The wrist is swollen and painful. We do an x-ray and it looks normal. Well, we know that the growth plate was injured. So there's an injury to the growth plate that doesn't show up on x-ray. The growth plate can break here and then take a big chip out of the longer part of the bone. The growth plate can break here and take a chip down here into the joint. It can get both, and it can actually get smushed if you jump off the garage and land stiff-legged. Never heard that before, but or what's the favorite one? Trying to see if you can do the Mary Poppins thing by jumping off the top of the swing set with the umbrella. I'll tell you, it doesn't work. So one of the things that happens with the growth plate injuries is almost all the time they heal fine. But sometimes the fracture itself disrupts the growth, and the growth plate can be injured to the point where it stops growing, it speeds up growing on one side, or it grows crooked. And those are all things that are sort of determined at the moment the child hits the ground. I have techniques for dealing with it, but when I see a child with a growth plate injury, I always talk about, now this could go slow, go fast, grow crooked, but I can fix it later on. So it's just something that just to be aware of. There are a couple of special kinds of kids fractures. Those of you that have had children that have gone to the emergency room, maybe you've heard the term Greenstick Fracture. Well, if you think about how a green twig actually breaks, it'll snap on one side and be just bent on the other. And that's exactly what happened here. This happens to be a child's shin bone. This is the knee. This is the growth plate. Here you can see that one side of the bone is intact, and here you can see this sort of dark gap. Well, on x-ray, fractures are black or dark. So this is a greenstick fracture. The bone partially breaks. Here's just sort of a cartoon of it. Again, notice one side is fine and the other side broke. Another type that's fairly common is called a Torus or a buckle fracture. Again, this represents a unique injury to children. One side of the bone bends and doesn't break. So again, this is a picture, or here's a picture of a child's hand. The fingers are up here, thumbs there. This is the radius. You'll see that this edge over there is straight, and you come down over here and there's a little bend. Again, think of this as bending a soda straw. It kinks on one side and it's pretty much fine on the other. Most children's fractures we treat with immobilization. In the bad old days, we used to put casts on everybody. Nowadays, we have some wonderful splints that do as good or a better job of immobilizing the fracture. But if you're careful, you can take them off and wash. Those of you that have had a cast or had a child with a cast know they get really smelly after a while. So this is something that it's a nice trade-off. Children heal pretty quickly. Broken bones are a 4 to 8 week process for the most part. Some of them take longer. If you manage to break your shin bone or your tibia, that's a 12 to 16 week process, but that's a bigger bone, it's a different issue. But like I say, most children's fractures are not operated on. They're treated with immobilization. Sometimes if the angle here is too big, I recommend that we go to the operating room and straighten it out. Children will grow straight. There's a magic number depending on how old the child is and how close they are to skeletal maturity about how big an angle I can accept before I have to do something. So most of the time we immobilize it. Sometimes, depending on what it looks like, sometimes we'll go to the operating room. Moving up in the age category a little bit. After childhood and sort of young adult skeletal maturity, then one of the more common things that we see is the ACL or anterior cruciate ligament injury. I kind of like this cartoon. It really doesn't look like that when it happens, but nowadays people know the term ACL. Everybody knows, oh, I blew out my ACL. Usually when I see somebody in the office, they say, my knee gave out. It's oftentimes associated with sports, but it can be some type of high velocity, high energy, high angular momentum event. Slipping in the kitchen is a pretty good way to tear your ACL too. You do not have to play soccer. The typical problem is twisting the knee while running or cutting. So it's typically the foot's planted, the leg goes like this, and you go that way. And what happens to the knee is it goes like that. So here's a pretty good picture. You can imagine that guy might come and see an orthopedic surgeon in a little bit. So here's sort of the anatomy. This happens to be a left knee. This is the outboard side. This is the inboard side. The kneecap is missing. The two ligaments inside the knee that cross, the anterior cruciate ligament, and then there's one in back of it called the posterior cruciate ligament, they act as guy wires to prevent the knee from shucking back and forth. And this is what it looks like when I scope somebody's knee or at arthroscopy. These two bumps here and here are called the femoral condyles. They are on the end of the thigh bone. The space in here is called the intercondylar notch, or between the condyles. And here is an anterior cruciate ligament that looks normal. But I tell folks, like some folks want to be awake in the operating room when I scope their knee, so I'll give them the little tour, but it's supposed to look like a bright, shiny, white, frozen waterfall. So this, I'll tell you, this is normal. And this is the posterior cruciate ligament, or PCL. Looks normal. So this is what it looks like if you've torn your ACL. Here is the posterior cruciate ligament, bright, shiny, white, and smooth, and there's no white frozen waterfall over here. It's gone. Some fun facts. What do people tell me about when I see them for presumed ligament injuries? They'll oftentimes report a pop. They will sometimes tell me, my teammates heard celery cracking. My teammates heard a carrot snapping. The knee will swell very quickly. The only thing that will make the knee swell quickly is blood. When the anterior cruciate ligament has a blood supply, when it tears, the knee fills with blood. It usually takes about 20 or 30 minutes to fill up. So if I see somebody and they say, oh, I hurt my knee, and it swelled up, and my question to them will be, right away or a couple hours? And if they say, oh, a couple of hours, then I'm thinking it's probably not a ligament injury. The reason it being is if it takes hours to fill up, it probably is the cells inside the knee that are making extra knee fluid or synovial fluid, and they're doing that. The other comment people tell me is that the knee, they can't trust the knee. It's unsteady or it's a trick knee. And like I say, that the anterior cruciate ligament, or ACL, is important for being able to make a turn or a pivot on your knee. And so if somebody will say, I can go in a straight line fine, but I have problems going around a corner, or I can run, but I can't play basketball, then I sort of suspect that. Here's another thing. Everybody knows this, but even in orthopedics, men and women are different. Here's the graph for ACL injuries by compared men to women. For reasons that we don't know, for equal levels of athletic endeavor, women tear their ACLs at a much higher rate than men. For a while, we thought that this was training. It's not surprising. The anatomy of men and women is different, even for the musculoskeletal system. And so there were some thoughts that because of the shapes of women's pelvis and the alignment and the way that the muscles attach, that women are predisposed to ACL tears. Some specific training for teaching women how to jump and how to land, and specific strengthening for women has been able to reduce the rate of ACL tears in women, but it's not the same. It's for equal levels of athletic endeavor, women will tear their ACLs more than men. Injury and treatment. The tears don't heal. If you tear your ACL, it will not heal. Sewing the ends of the ACL together don't work. This was discovered in the late 60s and early 70s at the Military Academy at West Point. Maybe you all know, but the Military Academy, the cadets and midshipmen are all very athletically active. They get hurt a lot. So they have orthopedic surgeons that are actually stationed at the military academies. There happened to be one at West Point who thought they could sew the ACL tears back together. Well, what happened is the cadets got their ACL tears sewn back together. They went off after graduation. They came back to teach. The same orthopedic surgeon was still there, and he was looking at all of these guys whose knees were sort of like wobbling around like that, and then decided, I guess sewing them together doesn't work. So there are some options for non-operative treatment. If you are not terribly athletic, if you are older, and we can always have an argument about how old is old, but if you are older, not very athletic, don't want to have an operation, you don't have to have an operation. Hallmarks of non-operative treatment are to strengthen the muscles around the knee, the ones on the front of the thigh, the quadriceps, the ones on the back of the knee, or the hamstrings. If you strengthen those muscles sufficiently, you can probably get away with not having your ACL reconstructed. You will be able to run in a straight line, probably won't be able to play handball, probably won't be able to play squash. You could probably play mixed doubles, church league tennis. But you're probably not going to be competitive in the Parks League. Operative treatment. If we're gonna operate for an ACL tear, it has to be reconstructed. It's not a repair. And so what we do is we need to get something that duplicates the anterior cruciate ligament. There are lots of options. The gold standard, the one that everything is compared to, is taking the middle 1/3 of the kneecap tendon with a block of bone off your kneecap and off the shin bone where it attaches, drilling a hole in the shin bone that comes up in the middle here, and then drilling another hole inside the end of the thigh bone, and then you take the kneecap, you take the tendon or whatever you're going to use and pull it up in there and fasten it. There are some other options other than using your own stuff. You can use a hamstring tendon and, for lack of a better description, dead people parts, cadaver grafts. Cadaver grafts are very popular because you avoid the problem of taking a graft. This is a rob Peter to pay Paul. If I take your hamstring tendon to reconstruct your anterior cruciate ligament, you're going to be missing a hamstring tendon. If I take the middle 1/3 of your kneecap tendon, you may have some kneecap pain. If I use something from the tissue bank, you're not going to have those things to deal with. However, you are exposing yourself to tissue-borne disease. The material that we use from the tissue banks is as safe as scientifically possible, but there's a risk of tissue-borne disease. And so that's a discussion that I have with the folks. Do you want your own stuff or somebody else's? I would tell you, overwhelmingly, my experience is people want their own parts, and they're unwilling to accept even the slight risk of a tissue-borne disease. Now we're sort of getting into the older folks area. If you are old enough, you might think about joint replacement, and that's called arthroplasty. And all that is realignment or reconstruction of joints to relieve pain. An exceptionally popular operation. I wind up doing this, I don't know, in Waupun it's probably like 3 or 4 times a month, which for a small hospital is a lot. We can replace hips, knees, shoulders, ankles, knuckles. You can also replace the discs in the spine. This is a pain relief operation. It works for relieving pain. Here's another thing. It is completely elective. Nobody has to have a joint replaced. What I tell folks is if you hurt and you don't want to put up with it and you don't like the other things that we have to offer, you can get your joint replaced. When does that happen? You have to be old enough. And old enough is a very, very difficult concept. Here's the problem. The parts that we use wear out. And I can give you some to look around, to look at. This happens to be a hip replacement. There's a socket, there's a ball, this part goes in the thigh bone. If you look at it, you see it's a mechanical system. And you can sort of pass that around. It's metal on plastic. It will wear. And wear starts immediately. We like you to keep your own piece as long as possible. We like you to try other things first. Having said we want you to keep your own pieces as long as possible, invariably, my patients tell me they waited too long. But I'm never going to tell somebody you have to get a replacement. You never have to get a replacement. You may want to, you may think it's your best choice, but you never have to. How do I do it? Well, for knees, we open up the knee and machine off the pieces on the end. And this happens to be a model of a knee. There's a pink one for girls and a blue one for boys, but so you can take a look at the pieces there. But basically what I do is open up the knee through an incision. This is surgery. Everybody gets an incision. We can. People are concerned about how big is the incision. I will tell you, all surgeons make incisions that are big enough to do what work they need to do. They heal from side to side, not end to end, so it doesn't make any difference how long it is. I machine off the thigh bone so that it matches the implants, and I have some cool looking stuff to do that. I didn't bring the things in for the knee, but I have the stuff for the hip. But basically, I use power tools, a drill, a saw, then also some other, not really power tools, but hammers. And the components are, the cuts are made to fit the components. I machine off the thigh bone, the shin bone, and in the knee, I glue them in for almost all of the time. We use some very, very fancy stuff called bone cement. Those of you that work on cars, it's actually Bondo, but we get the good stuff, not Bondo. And then this piece on the end of the shin bone, end of the thigh bone is invariably metal. There's a metal piece on the top of the shin bone, and then there is a plastic spacer in between there. So that's where one of the reasons why we want you to keep your own pieces as long as possible. Wear happens. The things will wear out. And the body sometimes recognizes those wear particles as an infection, although it's not, and will start to attack the joint and cause it to loosen up. So we quote, 85% of joints last 15 years. And you say, whoa, that's great. That means that 15% of them don't. So when I see somebody, I don't know what group they're going to be in. I hope they're in the 85% group, but they might be in the 15% group, and there's no way that you can predict that in advance. The hip. Again, how do I get into the hip? There are a bunch of different ways that are important to me as the surgeon. I can go from the front, the middle, the side, the back. I can go from the side to the front. But if you take a look at the picture here, basically I have to machine the thigh so that it fits the implant. I have to machine the socket or acetabulum so it fits the implant, and then impact or glue in the components. With hips, most of the time we impact the stuff. And those of you that work in the operating room or have gone on YouTube to watch this stuff, it's a big hammer, and I take a full swing. This is not delicate stuff. The pieces that are being passed around now, when it gets to you, if you feel it, you'll feel a little bit of a rough spot on the top of the thigh bone piece and rough spots on the back of the acetabular, the socket piece. The bone actually grows into those holes or pores. So what happens with, it's called ingrowth, basically, is your body, or the patient's body, actually holds onto the bones by growing into them. And it's a very, very, very strong bond. If I ever have to take it out, it's a huge, horrible project involving hammers, chisels, saws, and a big slap hammer to try and get it out. Going slightly into the sort of the older population. Like I say, joint replacements is you have to be old enough, and how old is old enough? If you're 50 and you want your joint replaced, I'll do it. If you're 30, probably not. But hip fractures are pretty common. This is one of the few areas where we talk about conservative versus operative treatment and talk about risks and benefits of each. In hip fractures, surgery is the most conservative way to take care of this. There is an option for non-operative treatment for hip fractures. I've done it in, I don't know, 20, 25 years. I've done it twice. Traction. Not operating on a hip fracture exposes people to greater risk than the operation. Things we worry about are pneumonia, blood clots, pressure sores, and a poor outcome. Basically, if you are old enough to break your hip and you decide not to get it operated on, I almost guarantee you will never walk. You will probably never get out of a wheelchair, and you might not ever get out of bed. But there are circumstances when that's appropriate. If you're too sick for an operation, that might be what happens. Another thing that we need to talk about very briefly is that hip fractures are a marker for bad things happening. This is a number that I talk with families about all the time. Grandma falls down, breaks her hip. There is about a 25 to 33% chance that there's going to be something really bad happen in the next year. The risk of death following a hip fracture is dramatically elevated compared to the population, and we don't really know why. Yes, it's a major injury. Yes, there's a major operation with no planning, but hip fractures are markers for bad things. And I can fix people's hips. I can make the x-rays look great, but that sometimes doesn't change the outcome. Not everybody who falls down breaks something. Only about 2% of the falls generate a hip fracture. The most common cause is brittle bone disease or osteoporosis. A fun fact, osteoporosis has to do with bone strength. One of the markers that we use for bone strength is bone density. Bone density increases up until skeletal maturity. Skeletal maturity is menarche for women and maybe 25 for guys. Bone density slowly decreases as we get older and plummets at menopause for women. Guys have sort of a long, slow slide. It's genetic for the most part. There are some things that can be lifestyle things. If you smoke, if you had steroids, if you drink a lot of diet soda, those are all things that can cause osteoporosis. But because of the demographics of men and women, it's not a secret there are more older women than there are older men. Most of the people who break something are women. Women who injure things tend to be older than men. There are about 1/3 of these a year that happen in the US. Here's a picture of a hip fracture. And you don't have to be an expert at looking at an x-ray, but you just sort of go up here, you see this smooth line, and then there's a big turn here. You go here and you see there's sort of something here. You go up here and you see there's sort of a jagged edge. This is a special kind of a hip fracture. We sort of regard these things as not quite emergencies, but they should be done sooner rather than later. How do I fix this stuff? Well, the first thing that we do is we line up the bones. I have a fracture table that actually I'm able to pull really, really hard to get the bones to line up, and then I put something in to hold it. And I'm going to give you a pass-around thing. I'll tell you that this is a thigh bone, and if we go back to this picture here, it broke about in this area. So what we do is line it up and put something in there to hold it, a plate or screw, or this cool gadget. What I do is drill a hole down the end of the thigh bone, put the rod in, and then there's a bolt that goes up here, and another one that goes down there. It's a lot of fun for me, but maybe not. Sometimes the fracture is so bad that I can't fix it. Or alternatively, if the fracture is not that bad, but the person is probably not going to be able to cooperate with the rehab requirements, I go ahead and replace the upper end of the hip, half replacement or hemiarthroplasty. And sometimes, very rarely, I will actually go ahead and replace somebody's hip because they broke it. Again, another way to hold these things, the fracture is here. Again, I open up the hip, drill, put this big lag bolt up there, then I put this plate on the side and fasten it with screws. Again, fun stuff for me, but not perhaps so much for everybody else. So here's an example of what this looks like before and after. And again, remember please, on x-rays, fractures are dark lines. So here's the dark line. This is looking at a left hip from the front. This is looking at the left hip from the side. There's the dark line. Here's the piece that's going in. Again, I've lined up the fracture. I make an opening up over here, drill a hole down the middle of the thigh bone, put this down. There's another little opening I make up over here, put that up there. And then there's some fancy hardware that I use in the middle to hold it all together. This is maybe a little bit more of a significant fracture. Again, if you sort of look at it, you say, well, that doesn't look right. And hey, there are 3 pieces here. But again, the same type of thing. I line it up and I hold it with hardware. And again, the same, there are literally hundreds of different kinds of hardware that I have available that drive the operating room staff because they say, no, I want, this or that or the other thing. But basically, it's lined up and it's stabilized above the fracture and below the fracture. And most of the time, it works out well. Here's an example of half a joint replacement. I'll tell you, here's the fracture right there, and we put a red and yellow lines on it so you could see it. In this circumstance, we decided, hey, this might not be so good to just fix. So let's go ahead and replace it. And so here is half of a replacement. Here's the thigh bone. There's the pelvis. This is the socket or acetabulum. And great big ball goes into the acetabulum. And this is glued in. In this type of operation, it's technically feasible to get up off the operating room table and walk on it. We don't let people, but when I finish closing the skin, it's done. You can stand on it. And so these are situations where I might do this because the person maybe has some dementia and can't cooperate with, Grandma, just put your toe down. So, like I say, we have a whole lot of different ways of dealing with this. So that's sort of it. That's sort of like babies to geriatric folks. There are lots of places that orthopedic surgeons can enter your lives. We don't all operate on everybody all the time. It's not that scary to come and see us. We generally talk to people first, and we are the folks that know the most about the musculoskeletal system. So if you have a bone or joint question, you ought to ask an orthopedic surgeon. And that's what I got. So if there are any questions, I'd be happy to entertain them. I have a whole lot of other orthopedic instruments that you can look at and feel if you want to. I don't know if passing them around makes much sense. But thank you very much for letting me talk to you.
Thank you, Dr. Grossman.
Oh, yes. Sure. Those are orthopedic surgeons love classification systems. And Salter-Harris fractures are these types of injuries to the growth plates. Salter-Harris 1 fracture is an injury to the growth plate that doesn't show up on x-ray. So this is the swollen wrist and swollen painful wrist that looks normal. This is called a Salter-Harris 2 fracture, which goes up. This is, if you want the term, this is diaphysis, this is metaphysis. Doesn't make any difference to you guys. This is a Salter-Harris 3, this is a Salter-Harris 4, and the crush injury is the Salter-Harris 5. The bigger the number, the more likely you are to have a growth plate problem. Any growth plate, so they're for children, right? And like I say, that skeletal maturity happens in girls at menarche. In guys, it happens later. The last growth plate to close on guys is the medial border of the clavicle, which closes at about age 22 to 25. So yes, guys are slower than girls. Other questions? Yes, ma'am.
When it comes to hip and knee replacement, are there any weight limits, patient weight limits that become ineligible for?
It sort of depends on the weight limits for hip and knee replacements. It sort of depends on the courage of the orthopedic surgeon. Some operating room tables are limited at 500 pounds. The bigger the person, the harder the operation, the poorer the outcome. So if you weigh if you weigh too much, you might be sent to some place where the equipment is suitable for you. But the actual implants themselves can probably withstand much more than the weight of the most obese person. But if the person is so heavy that they can't participate in the rehab, then maybe they're not a good candidate. So it's kind of it's a very judgmental question. There are some surgeons that will not operate on people whose body mass index is over 35. Okay, and so body mass index of 30 is overweight, or over 30 is obese. So modestly obese, some people will do. Some people will not operate on anybody whose body mass index is over 25. They don't, in Wisconsin, that's kind of unusual. But there are people in referral centers that will say, no, go someplace else, I won't do it. So, other questions? Yes, ma'am.
What would make a knee replacement wear out faster than the next phase?
There are a couple of things. The alignment is pretty critical. The question is knees wearing out faster than others. One of the things is alignment. This sort of medieval looking thing is the jig that we use to cut the top of the shin bone. And so it goes around the ankle here. This part goes up. This part rests on the top of the shin bone. And then this is pinned to the person. And then the saw blade goes in and I make the cuts. So here, you can have a look at that one if you want. Alignment is critical. If it's horribly out of alignment, it's going to wear faster. There were some implants that wear faster than others. And sometimes it just happens. There's no, like I say, if it's lined up pretty well, it should last, but sometimes it doesn't. But that is part of medicine, is making decisions in the face of uncertainty. It doesn't make any difference what kind of doctor you are, it's all the same. Doctors make decisions based on history, physical examination, and other studies. And if all of those things interact at one point, and you make a diagnosis, and you make an intervention, it doesn't make any difference what kind of intervention. If you're an internist and you're talking about blood pressure, and you say, hey, this little green pill is really going to fix that blood pressure, 85% of the time it works. 15% of the time it doesn't. The same thing with knee replacements. They're supposed to last that long. Some of them don't, and we don't really know why.
So it's not the use of it?
Yeah, I mean, maybe. If you are a marathoner, you might wear out your knee a little faster. Hip and knee replacements are not designed for high-impact activities. Although, having said that, I did a hip replacement on a skydiver. And I told him he's on his own. They're not designed for that. So if you take, remember please, these things are mechanical systems. It's just like any other mechanical system. If you start operating outside the design parameters, let's say you have a pickup truck, and it's a half-ton truck, and you put 5 tons of bricks in the back of it, it'll work fine for a while. If you drive it 70 miles an hour, it'll work fine for a while. But then it may wear out. And so if you are, like I say, if you do unusual things, if you take the knee or the hip and operate it outside the design parameters, it's probably going to wear out faster. But some of them, you do everything right, it looks fine, the operation was easy, it's a thin person, they're listening to what the doctor tells them, they're doing all the right stuff. Sometimes it just doesn't last. We never know why.
Is there always a possibility that one leg is longer than the other when you're done with knee replacement?
Knees, rarely, hips sometimes. Most everybody has one leg longer to start with than the other. Or actually, let me rephrase it. About half of people do. In World War II, they x-rayed the entire Canadian Army. Half of them had one leg longer than the other. A quarter was the right, a quarter was the left. So in knee replacements, we generally don't change the length all that much. In hip replacements, there's sometimes, first of all, if you start off with significant arthritis, it's probably short to start with. And in the operating room, I have to make a trade-off between hip steadiness and length. Let me see if I got one here. So here happens to be a hip replacement. This is the thigh side, this is the femur side. There's no mechanical connection between these two, okay? The only reason that the hip stays where it's supposed to, or located, is because of geometry and gravity. So if you get out here, it's going to come apart. So in the operating room, I have to make a decision between steadiness and leg length. And I will trade leg length for steadiness any day. And I'll tell people, you may wind up with one leg longer than the other. We'll put a lift in your shoe. But a hip joint that dislocates is a disaster. And so I will do everything that I can to make sure that it's steady in the operating room. And I tell people ahead of time, you might wind up with one leg longer than the other. And my experience is if you tell people what to expect ahead of time, they're not surprised. And like I say, if in hip replacement, you almost always have one leg longer or shorter than the other one to start with. And sometimes I can make it level, and sometimes I decide not to. Okay? Sure. Other questions? Yes, ma'am.
What is your professional opinion on using chiropractic services?
It's a lot like religion. You either believe in it or you don't. Chiropractic care is safe and effective, and many people find relief for spinal problems. And I don't care how people get better. If you've got a sore back and you want to go see the chiropractor, fine, great. They provide wonderful services, to many people, and many people swear by it. It's, like I say, it's a lot like religion. You either believe in it or you don't. I think that it's part of the spectrum of healthcare. Other questions? Yes, ma'am.
What made you decide to be an orthopedic surgeon?
Oh, what made me decide to become an orthopedic surgeon? I was 14 years old. I was skiing at Wunderberg, which is now Sunburst, and I went down that side hill, and I was doing going over the moguls, and I went up on the tips of the skis to go over the mogul, and I landed, and I was wearing cable skis, cable binders, and the cable tensioners popped. They didn't release me, and I did a forward spread eagle somersault, and I wound up with compound tib-fib fractures. And I met an orthopedic surgeon, and I thought what he did was cool, and that's how I became interested in it. Other questions? All right. Well, I think we're out of time, so thank you very much.